Arungo said, this session is about injectables, and it's very nicely designed because both injectables have been put into one symposium, which makes it very interesting as to what should come first, what should come second, should they come combined together, etc. That's very nice. Insulin part comes later. The GLP-1 RA part comes first. Now, when we talk of incretins, incretin is not only GLP-1 RA. Incretins also includes DPP-4 inhibitors for all my friends who are listening to me. And I think probably amongst all of us who are listening, the ratio of using DPP-4 versus GLP-1 RA in your practice probably would be something to the tune of 9.5 is to 1%. Majority of us are using DPP-4 inhibitors. We are not using GLP-1 receptor agonists enough. There are many reasons to that, and we'll discuss about the various reasons as we go along. As this slide says, this is a session sponsored, and I'm contracted for this talk. However, as the second line states, the views expressed are purely mine and do not necessarily reflect the opinion of the company. So I will first start with a lot of discussion happened about management of diabetes. I will start with the importance of glucocentricity. Before I go into that, I always say that diabetes is a holistic management. Glucose is one of the many parts when you manage type 2 diabetes. You have to pay a lot of attention to getting the blood pressure under control, to get lipids under control, to get your patient off smoking, moderate alcohol intake, and as was discussed in the previous session in great detail, lifestyle modification. Get them to exercise, get them to exercise. UKPDS, when they were being recruited in the initial screening phase, lifestyle alone reduced HbA1c by dramatic 1.5% up to 2%. So lifestyle is very, very important. Having said that, once you've got the blood pressure under control, which is difficult but not so difficult, lipids is the easiest to control if your patient takes the medication. The most difficult part of managing type 2 diabetes is the lifestyle bit and the glucose control bit. So now moving on to the glucocentricity part, this has been shown many times. A few of the landmark trials during the National Insulin Summit in 2015, which is always organized with such fanfare and in so much detail by Professor Das. It's an honor to be a part of NIS. In 2015, the names you can read there, we got together and we made a consensus statement of the implication of various landmark trials. I'm not going to type 1 diabetes, I'm going to type 2 diabetes, and these 4 trials have been discussed ad nauseum. What it tells you is one takeaway point, not for my seniors or for my colleagues, but my friends who are general physicians or primary care physicians. For you, the take-home point is glycemic control matters. Obviously matters, no matter whatever you say. Certainly, lipid, blood pressure reduction is important, but glycemic control is very, very important, as was discussed in the previous session when we talked about nephropathy, retinopathy, and peripheral neuropathy reduction. There's absolutely no doubt, take which of these 4 landmark trials, good glycemic control. As you can see, the difference in the HbA1c, 9% here, about 1.1% here, 0.7% here, and about 1.5% difference in the treatment arm as opposed to the tight control as opposed to the standard arm. With that difference, you had unequivocal reduction in microvascular complications, and there was suggestion that there might be prevention or reduction in cardiovascular complications, primarily if you see with the UKPDS trial, and UKPDS the extension trial also showed there's probably reduction in cardiovascular mortality. With regards to microvascular complication reduction, there's absolutely no doubt. And this was what was being discussed again in the previous session. Once the UKPDS got published, look at what happens to various macrovascular complications. Myocardial infarction, stroke, these are the events per 1,000 adult population with the diagnosis of diabetes. From about 130 odd events in 1990, it comes down to about, you can put a number there, would be about maybe 60. So almost 2.5 times reduction in myocardial infarction. With regards to stroke, as you can see, starting from 110 odd plus, you're coming down to about 60 odd plus, almost a 50% reduction in stroke events. Things which have not changed is if you see the amputation risk, it's come down very mildly. But having said that, the data is slightly old, 2010. And as was being discussed in the previous session, there hasn't been much improvement in the ESRD. Reason being, Glycemic control, blood pressure control, lipid control, ACE, ARB has been there for a long time. Things are going to change now because SGLT2 inhibitors unequivocally have beneficial effects on renal function. Now, if you want to get good glucose control to prevent microvascular complications, possibly macrovascular complications, that's the good side. But the bad side is you're stuck with hypoglycemia. This is data from advanced trial. Advanced trial was strict control versus standard control. They happened to use gliclazide in the strict control arm, but both arms, quite a substantial number of patients were on insulin. So there was hypoglycemia. But point number one to note in the advanced trial is severe hypoglycemia in such a large trial with people with type 2 diabetes, advanced diabetes, severe hypoglycemia, if you see, this is 1%, okay? 1 in 100. So this is 1%. This line is 1%. So it wasn't very high. Severe hypoglycemia, despite use of sulfonylurea, insulin wasn't so high. So one of my messages to my colleagues who are listening to me, primarily my primary care physician colleagues, is don't be too hesitant about hypoglycemia. Be careful, certainly, but don't be too hesitant. So it's but obvious that when you're using intensive arm, there will be increased risk of hypoglycemia. And this was subsequently found that hypoglycemia was associated with increased risk of major cardiovascular event, all-cause death, or CV death. Having said that, this paper came out in NEJM, caused a lot of hoo-ha, but certain points to be noted. Look at the number of patients who had severe hypoglycemia, 231 as opposed to about 10,000 patients, almost 11,000, no severe hypoglycemia. So this huge cohort of patients followed up for quite a substantial period of time. Severe hypoglycemia was quite less, with very small number of patients. And given these numbers, it's very difficult to compare. Of course, you can do statistics. You can come up with a hazard ratio and say 2 to 2.5 times increased risk. But take it with a pinch of salt because the number of severe hypoglycemia episodes were quite less. And also, the important point to note is below in this blue box is associated. Now, it's not necessarily that hypoglycemia caused it. It's possible that people who had these bad cardiovascular outcomes had other reasons where probably they were not eating well, they had other issues which cause hypoglycemia. So association is not causation. But having said that, hypoglycemia is an important risk factor for cardiovascular events. So our landmark trial tells us to get good glycemic control, but while doing it, we have some issues, some problems. We get off-target effects, like we get hypoglycemia, we can end up with weight gain. I mean, it's very well known with insulin, you gain some weight. With sulfonylureas, even the modern ones, you may gain some weight. So these are the drawbacks when you're trying to get good glycemic control using the drugs which were used in UKPDS, sulfonylurea, metformin, and insulin. For that matter, even in the advanced trial, it was sulfonylurea, and a big chunk of people in both arms were on insulin. And as Dr. Karango mentioned, that as you keep managing diabetes, as time goes on, many of them will end up on insulin. So this is the issue that you have. If you want to follow landmark trials, want to get good glycemic control, 7%, as UKPDS said, you may end up with some off treatment targets. So now in modern day, if affordability is not an issue, you would like to use medications which either have no risk of hypoglycemia or very low risk of hypoglycemia, who do not cause weight gain, and for that matter, not only do not cause weight gain, but cause weight loss. And you just heard in the previous trial about about fatty liver, fibrosis, and weight and diabetes. Even a 5 to 7% reduction in weight can have dramatic effects in your fatty liver and in your NASH score. Get good glycemic control, and on top of that, give you the benefit of cardiorenal protection. So with that in mind, let's see, after metformin, what drugs can you add? Commonly, and don't get me wrong, worldwide, the most common drug after metformin, used after metformin, is sulfonylurea. In any country you go to UK, go to USA, come to India, it's sulfonylureas. Despite increased hypoglycemia, despite weight gain, despite uncertain cardiovascular safety, reason being only one, or reason being two. One is the cost, and second is because it's been there for a long period of time. All of us have grown up using sulfonylurea, so we would like to use sulfonylurea. I think 10, 15 years later, people who are growing up now, our junior colleagues, they would probably will not be so familiar with sulfonylurea. So maybe 10, 15, 20 years time, the statistics might change. All of us are using DPP-4 inhibitors, the other incretin. Efficacy is intermediate, as you will see later on. They do not cause hypoglycemia if used on their own, very rarely. They have no effect on weight loss. They are weight neutral. And saxagliptin has this problem, maybe allogliptin, which is also now coming into India, increased risk of heart failure, hospitalization. SGLT2 inhibitors, yes, they are giving a big fight to GLP-1 receptor agonists. No. Weight loss, yes, they have CV cardiac benefits, but their efficacy is not, when you compare with GLP-1 receptor agonists, they're not as efficacious as GLP-1 receptor agonists. So coming to GLP-1 long acting, very high efficacy. I won't say as good as insulin, as some studies show, but I would say they are quite good. No, hypoglycemia is not right. Very rare hypoglycemia. They may cause weight loss, do not cause weight loss all the time, but they may, same with SGLT2, may cause weight loss in a great majority of patients that are using GLP-1 receptor agonists. They also decrease major adverse cardiovascular events. Out of the 8 GLP-1 receptors available worldwide, 4 of them have got evidence pertaining to that. Their main drawback is GI side effects. Now, these are the various GLP-1 receptors available as of date throughout the world. If you take US and Europe, all of them have been licensed. If you come to India, just see the green tick on the right hand side: exenatide twice daily, exenatide, no, liraglutide, dulaglutide, and lixisenatide. These are the 4 which are available to us. Amongst these, the commonly used GLP-1 receptor agonists amongst the doctors or physicians or diabetologists or endocrinologists who are using it as basically liraglutide and dulaglutide. Now, if you see, these are the brand names, and these are the very funny names you have for all the trials that they've gone through. Now, the beauty about the newer anti-diabetic agents are they have a rigorous trial data backup, as say whatever you want to say, compared with placebo, compared with sulfonylurea, compared with any other competitor, compared with insulin, compared with the basal bolus regimen, every kind of comparison all GLP-1 receptor agonists have, all DPP-4 inhibitors have, all SGLT2 inhibitors have. That is not available with the earlier drugs, sulfonylurea, or for that matter, let's say acarbose. Now, the names that we should remember in India is Amigo, Lead, I think we all know, Award, I think we all know. Get Goal, many of us don't know, because I think the use of lixisenatide, I might be wrong, we can take it in the discussion session, is not so widespread in India. Now, coming to GLP-1 RAs, what all do they do? This is what when you're managing diabetes, this is what you want to manage: blood pressure, blood glucose, body weight, blood pressure, lipids, and the question mark, which will be opened up later. And then you want to reduce atherosclerosis, and this question mark, you want to reduce that issue, and you have CV risk reduction. So this is the ballpark HbA1c reduction. Now, any slide you see is never complete because each study is different. It always depends on what is the baseline HbA1c. Higher the baseline HbA1c, more is the drop in HbA1c. Having said that, if you take across RCTs, the reduction is anywhere between the lowest with exenatide and lixisenatide, because they're shorter acting, they're given once or twice daily, is about 0.8%. And when you come to the longer acting ones, especially semaglutide, you see quite good reduction. Same with dulaglutide, 1.4 to 1.5% reductions. Now, this is the reduction in the HbA1c in the various cardiovascular outcome trials. So these were not glycemic control trials. These were cardiovascular outcome trials where they were trying to get glycemic equipoise so that they can assess the effect of the molecule in cardiovascular outcome. But if you see in all the cardiovascular outcome trials with GLP-1 receptor agonists, they failed to get glycemic equipoise, HbA1c reduction being 4%, 0.4% and above with any of the GLP-1 receptor agonists used in the cardiovascular outcome trials. Coming to body weight reduction, as I said in the beginning, you can always divide patients into a few subsections. Ones who have a huge weight loss, and this is the one which is presented in meetings by most of us, which show 12 kg, 14 kg weight loss. Mind you, these are exceptions. Then comes the middle group which have where they show the ballpark reduction in weight, which you can see here is anywhere from 1 kilogram to about 3.5 kilograms. And then, which none of us show, are the patients who have no weight loss, with GLP-1 RA. So giving GLP-1 RA will unequivocally cause weight loss is not true. One of the reasons we can discuss later is the dose that we are using for glycemic control as opposed to weight reduction. We can come to that in the question answer session. Now, again, if you see across CVOTs, you would rather have no weight loss so they can assess the effect of the molecule on the cardiovascular outcome, but there was significant amount of weight loss with all of them. As to how much this contributed to the cardiovascular outcome, we can again debate and discuss as we come to the question answer session. Coming to blood pressure, we all know that SGLT2 inhibitors is very easy to remember, 4 and 2, 4 millimeter systolic, 2 millimeter diastolic reduction. GLP-1 RAs also reduce blood pressure. If you can see this slide here, systolic reduction as much in semaglutide once weekly was quite massive reduction of 7 to 7.5 millimeter Hg systolic reduction, whereas others are ballpark figure of 2 to 4 millimeters, which we expect. And again, when you come to the cardiovascular outcome trials with the GLP-1 receptor agonists, for once I will say which are, this is lixisenatide, exenatide once weekly, liraglutide, dulaglutide, semaglutide oral, semaglutide by injection. And if you see, there has been a reduction in blood pressure. As to how much this contributed, we can again have a debate in the question answer session. Lipid metabolism, not too much of an issue. There is reduction in triglycerides. Again, if you see semaglutide scores, there is a slight rise in HDL cholesterol, 0.01. So multiply that by 38. So comes to very few milligrams per deciliter. If you come to LDL cholesterol reduction, also not very impressive. But what you can say is they are not harming, and triglyceride levels are coming down quite significantly with semaglutide. Now that the question mark opens up now, that question mark is inflammation. We all say that diabetes is a low-grade inflammatory disorder. It all started with the Jupiter trial. We started doing CRP, etc. And not much data available with GLP-1 and inflammation. Having said that, the Pioneer, which is the latest of the cardiovascular, latest of the GLP-1 receptor agonists, which is the oral GLP-1 semaglutide. In Pioneer 1 and Pioneer 2, they measured the C-reactive protein. And if you can see, this is the various doses, 3 milligram, 7 milligram, 14 milligram. And there's empagliflozin for comparison in Pioneer 2. In EMPA, there wasn't much reduction in the inflammatory marker C-reactive protein. Having said that, this is one of the many inflammatory markers, but there was statistically significant reduction with oral semaglutide, 14 milligrams. And here, if you see 3, 14, and 7, they had reduction in the C-reactive protein. So possibly GLP-1 receptor agonists are also having a little bit of an effect on the inflammation side story of type 2 diabetes. Now, coming briefly to the various cardiovascular outcome trials, this is a huge list. I don't think you need to see this. I will just show you the ones that you need to know. Now, before we go into that, as I said, the various benefits seen with cardiovascular outcome trials, was it because of the molecule? Was it because of other issues like HbA1c lowering, body weight reduction, systolic blood pressure reduction? Difficult to find out. If you see the semaglutide injectable and semaglutide oral, this is Pioneer 6, which is all the semaglutide oral trials, and the dark blue is sustained semaglutide once weekly. HbA1c reduction was 0.8 to 1%. Body weight reduction is almost 4 kilograms, and blood pressure reduction is almost 2.5 millimeter mercury. Quite a huge amount. The best hit is albiglutide. You see, albiglutide body weight reduction is not that much. Systolic blood pressure reduction is not that much, but they failed to maintain the glycemic equipoise. And despite that, they showed myocardial infarction benefit. So these are the nitty-gritty details. I don't think we need to go into so much detail. I think this is the take-home slide with regards to cardiovascular outcome trials and GLP-1 receptor agonists. If you see the 4 which are positive is leader liraglutide, sustain 6 is semaglutide once weekly injection. Harmony, which is albiglutide, which is not available anymore because the company took it off the market because it wasn't very efficacious as far as getting HbA1c control and weight reduction. And of course, Rewind, which is dulaglutide. Pioneer 6 did not meet the 3P MACE because it was not a trial designed to look for cardiovascular outcome trials. It was a trial done to get the drug into the market. Cardiovascular outcome trials was done to make sure it's non-inferior, does not cause any harm. The larger trial is going on called the SOUL trial, which I'll come at the end. So with that background, this is the latest, doesn't come out very well, taken from their website, latest 2021 standards of care, which is now differentiated heart failure and CKD separately. Previously, it was combined together. And they say that established atherosclerotic cardiovascular disease, you could consider either a GLP-1 with proven CVD benefit, the 4 that I showed you, of the ones that we have in India, both Lira and Dula have the cardiovascular outcome benefit, or an SGLT2. If there's heart failure, SGLT2 takes over, GLP-1 is not there. If it is CKD with or without albuminuria, if SGLT2 inhibitor is contraindicated. Now we can fight on that in the question answer session as to what GFR he would not be given, below what GFR he will not be given SGLT2. Then you could consider a GLP-1 receptor agonist, or in patients with recurrent UTI, GTI, pyelonephritis, recurrent balanitis, or vulvovaginitis, where SGLT2 you can't use and you still want kidney protection, you could think of GLP-1 receptor agonists rather than SGLT2 inhibitors. Having said that, this drug is not limited only for these conditions. It is primarily an anti-diabetic medication. It can be used in any type 2 diabetic patient for glycemic control with the added extra glycemic benefit, and in a patient who can afford. If cost is an issue, which is a big issue in our country, my friends, please go to the right hand side. Please don't this up again and again in the question answer session. Sir, what if my patient can't afford? Certainly, if your patient can't afford, go with metformin, sulfonylurea, thiazolidine, and rush to, after that, go to human insulin. Please don't start talking about GLP-1, SGLT2, DPP-4 for a patient who cannot afford those kind of medications. Having said that, we have a huge population of the type 2 diabetes, second to China now, and of these, a fair proportion can afford the drugs that I'm discussing today. We are discussing all throughout the day. To these people, don't deny what is available, which have unequivocal cardiovascular renal protection, plus gives you possible weight loss, blood sugar control, and very low risk of hypoglycemia. GLP-1, SGLT2, if you combine with sulfonylurea or insulin, then you may get a high risk of hypoglycemia. Which brings me to my last 7 minutes of my talk, which is introducing the newer GLP-1 receptor agonist in the market. Now, this is a very, very important slide. I think it's a picture slide. This is talking about GLP-1 RA. I can show you a slide like this about management of diabetes. Less than 15% of patients in India get the three targets of HbA1c reduction, blood pressure reduction, and lipid reduction. Less than about 30 odd percent patients get HbA1c under control, below 7%. So that is different. Here I'm talking about use of GLP-1 RA. I showed you the ADAESD guideline, which is almost similar in many countries. Here what they found was less than 10% of patients with type 2 diabetes and CVD received guidelines recommended therapy for CVD risk reduction, even in developed countries, which is so sad really. Despite talking of such big, big things, despite having so many CMEs, despite having so many meetings, look what you do. This is a huge database, English GP practice. 84,000 in this area had type 2 diabetes. 16.6% satisfied the leader. Leader was the liraglutide cardiovascular outcome trial inclusion criteria. And despite that, only out of 14,000, only 1,200 were prescribed any GLP-1, any GLP-1. And this is in UK, where it's probably funded. And only 5 out of 14,000 people who satisfied the criteria, i.e. they should have been on liraglutide, only 5.4% ever received liraglutide. And this comes from US, 5,000 patients. This was a different study about lipid lowering study, where they found that about one third had diabetes, majority were type 2 diabetes, and even here the use of a GLP-1 receptor agonist was less than 10%. So we are not using enough GLP-1 RAs. I can say the same for SGLT2, same for other drugs. Today being an incretin session, injectable incretin session, so I'm limiting myself to GLP-1 RA. So why is this happening? We'll come to that later on. One of the many reasons is injectable. I don't want to go through this slide. This slide has been shown in a different way in many meetings. It's common sense that if given a pill or an injectable, patient will always prefer a pill. And that is one of the reasons why probably so much work is being done on oral GLP-1 receptor agonists. But GLP-1 receptor agonists have got a lot of benefits. Injectability may be one of the reasons, not the main reason, one of the reasons which inhibits us to use it in a large number of patients. So now comes the first in class oral GLP-1 RA. This is not available in India, my friends, so far, but I hope and I presume it will be coming soon with a price tag which most of our GLP-1 RA savvy patients can afford. It's a new route of oral administration. Now remember, these are all peptides, just like insulin. If you take it orally, they are supposed to be destroyed in the gut by the pH and by the various degrading enzymes. Why it doesn't happen when you give semaglutide orally? The reason being, I'll come to in the next slide, is something called SNAC, which prevents that destruction. But because it is still destroyed to some degree, only 1% is absorbed. Those of you who have managed alendronate, fosartans, for osteoporosis will know very well. It's exactly the same. It only 1% of it gets absorbed. Variability in absorption is higher, and because 1% is getting absorbed, although semaglutide is a once weekly injectable, it has to be given daily when you give it orally. Semaglutide, we all know what semaglutide is all about. It's got 90% homology to human GLP-1, and this is the snack which, if you are interested, you're good in biochemistry. I think most of us were, but we've forgotten now. So that's the name there. If you want to memorize that, it's an absorption enhancer. It increases the bioavailability of the oral after oral administration. How it does that? It creates small pockets. Absorption of semaglutide requires co-formulation with snack. Snack was a small pocket of local increase of pH, leading to higher solubility and protection from proteolytic degradation. And then the drug slowly gets into bloodstream. Because it's a peptide, snack cannot protect most of it. So only 1% is getting absorbed. And that's the reason why you have to give it daily. And they, like any other newer oral hypoglycemic agents or newer injectables, huge number of a large scale trial has been done, which you can see 24 clinical pharmacology trials, one phase 2 trial, and 10 phase 3A trials. Now, I don't have the time or the inclination to take you through all these trials in the short period of time that we have. I'm supposed to give an overview of GLP-1s and bring your attention to the fact that these injectables are now uh, going to become available orally. Others I don't know, they are still on the drawing board. This is one which has already come, it's already been approved in USA. And these are the various trials which were done. They're called Pioneer trials, Pioneer 1, Pioneer 2 versus SGLT2, Pioneer 3 versus DPP4, Pioneer 4 versus other GLP-1 RAs placebo, Pioneer 7, 8, 5, 9, 10, the Japanese trials. And this is the ongoing cardiovascular superiority trial. This is a cardiovascular outcome trial which has got 650 Indian patients. This is a very busy slide. I don't expect you to look at it. Also, certainly look at it, please. But I don't think you can absorb the information so quickly. But what I will show you is a few facts. See Pioneer 2 versus empagliflozin, EMPA 25 versus Sema oral 14. Semaglutide oral can be given in 3, 7, and 14. 7 and 14 are the doses commonly being used. 14 is the maximum dose as approved. And if you see the HbA1 reduction, this small asterisk tells you that it's statistically significant. If you compare Sema 14 with liraglutide 1.8, also slight with placebo, it's definitely statistically significant. But with liraglutide injectable daily, there was no statistically significant increase reduction in HbA1c, which tells you, which is good for semaglutide oral, that oral drug with 1% absorption still gets you HbA1c reduction as good as liraglutide 1.8 milligram. In India, we mostly use 1.2. Some of our patients even are 0.6. And this, if you take Pioneer 8 with insulin, again, if you see compared to placebo, huge amount of reduction. With regards to number of people getting HbA1c less than 7, you can read anywhere between 50 to 70%. I won't stay too much on that slide. Now, change in body weight. Amongst all the GLP-1 RAs, semaglutide gets you the best body weight reduction, of which injectable semaglutide once weekly gives you the best weight loss. But if you compare oral semaglutide, change in body weight, let's compare with empagliflozin. Empa is GLP-2, we say, causes a lot of weight loss. Look at sema oral. It matches almost, we say, 2 to 4 kilograms. In this trial, they were 3.8 to 3.7. Now, if you come to comparing with liraglutide, it is more. Injectable semaglutide is more with liraglutide, we know that. But now oral semaglutide gives you a better weight loss. Again, in this trial situation, this is a trial situation, 26 weeks trial only. If you can see on the top, Pioneer 4, 26-week trial, baseline weight was 94 kilograms. But even in there, placebo 0.5 and 4.5, so 4 kilos extra weight loss. My last three slides, Dr. Kango, because it's an oral peptide, oral drug peptide mixed attached with snack, there are few do's and don'ts when you take this drug. It has to be just like if you remember your osteoporosis management before the injectable zoledronic acid came. We always used to use once weekly alendronate, and exactly the same instructions. Please remember, it has to be taken first thing in the morning. It has to be taken on an empty stomach with 120, half a glass of water. Wait at least 30 minutes before eating, drinking, or taking any other oral medication. Have your first meal and drink of the day and take any other medications you need. So basically, Only thing probably is not mentioned is that what was there in Alan Red was if you keep walking about for half an hour because of the GI side effects. Here that is not there, but you have to take it first thing in the morning, empty stomach, 30 minutes, nothing else can be taken with a specified amount of volume of water. And this automatically brings this question. My previous talk, I didn't have this slide. So now this slide is there. What happens to other drugs now, sir? You're giving this oral. You're saying there's so many restrictions. Now, if you take the area under the curve, Cmax, we don't worry so much. If you take area under the curve, anything more than 25%, you are concerned. If you see thyroxine, now this is the question asked again and again. Thyroxine, empty stomach, oral semaglutide when it comes to India, we'll give it empty stomach. So what to do? Answer is very simple. Wake up, take oral semaglutide, then go back to sleep. Then wake up, take thyroxine, brush your teeth. Half an hour later, have your tea coffee. So 1 hour you have to give. You can semaglutide and thyroxine on empty stomach. Or you may want to reduce the dose, but that you could check individually because there is area under the cover thyroxine increases when you are using oral semaglutide. Others, if you see, also increase a little bit. So digoxin, not much of an issue. Warfarin, not much of an issue. So maybe only with thyroxine, you might have to be little bit careful when you are using oral semaglutide as and when it comes to India. I don't know when it's going to come. So in one slide, pioneer clinical program was quite exhaustive. Pioneer clinical program is for oral semaglutide. So many patients have been exposed, so duration, low risk of hypoglycemia, has been quite well tolerated. So these are my two summary slides. Summary 1. Decline of beta cell function is the key driver of type 2 diabetes progression. This is the holy grail of diabetes. Remember, each word is important. It's beta cell function. I'm not saying beta cell loss, beta cell apoptosis. Professor Das very kindly gave me a very interesting topic to speak on the last NIS, where what we discussed about the beta cells in type 2 diabetes in cadaveric pancreas, where people have done a lot of study. There's a group called NPOD. So there is decline of beta cell function. GLP-1 analogs address 4 out of the 8 pathophysiological defects on their own. And if you use them with metformin, you're controlling 6 of the 8 pathophysiological defects. So to me, if affordability is there, the best combination would be metformin and the GLP-1 receptor agonist, plus minus if you can add an SGLT2. But that's a very, very expensive combination. We can discuss this in question and answer time. Now, if you add GLP-1 to metformin, you get all these benefits. This is the main limitation. We can say it 100 times. Cost. We can keep saying cost. That is the main limitation. Having said that, in my practice also, I cannot give GLP-1 receptor to anybody and everybody that I want to give. But when you बोलते हैं बात छेड़िए, बात छेड़ने के बाद 10 में से it's like शादी वाली बात ना. When you go to see a lady, you see so many, then one hits. Same thing. So you bring up GLP-1 receptor agonists with your patient. Many of them will say no, but some of them will take it. So timely treatment is needed to reduce complications. Yet many patients, more than 70 odd percent in India, do not achieve target HbA1c. There are many reasons to this. We can discuss later. Oral GLP-1 injection is an issue. So if you are using a GLP-1 in your small percentage of population in India where they're using GLP-1, if they could be switched from an injectable to oral, probably the acceptance will be more. Because many of us, I'm sure in the discussion we'll find, have patients who initiate GLP-1 injections, they get good results. After 6 to 9 months, when they come back, you ask them, what happened to the injectable? Oh, sir, I stopped it, they will not see the cost as the issue. They'll keep going left, right, and center. It's injectable, no problem, not available, nausea, vomiting, etc. So if an oral GLP-1 receptor comes, it's nice. It's available overseas. We are waiting as to when it will be available to us, and keenly waiting to know how much it's going to cost, because if it's too much, then many of the patients on injectables may not agree to go to oral. With that, I will stop. Dr. Kanungo, you had given me the injectable GLP part. So I have done that with the slant.
Thank you, JJ.
Thank you.
Wonderful talk.